From the JAMA Network, this is JAMA Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Surgery.
Welcome, JAMA Surgery listeners. This is Amalia Cochran, the web and social media editor for JAMA Surgery. And today I am talking about a randomized clinical trial examining quality of life in breast reconstruction patients with autologous fat transfer versus implants, or the breast trial, with Dr. Andrzej Piatkowski at Maastricht University Medical Center. Welcome.
Thank you very much for having me.
I always start our author interviews by asking how authors got interested in their research question. Your article clearly describes the limitations of the predominant reconstruction techniques following surgery for breast cancer. Why did you think it was important to examine autologous fat transfer specifically as an alternative?
Yes, you see, in my practice, I see a lot of patients who are coming to us for reconstructive purposes. So they have encountered breast cancer. They are heading towards an amputation of the breast. And then the discussion comes up about what to do next after the amputation of the breast. And mostly there was this possibility of doing flap-based reconstruction or doing silicone breast implants. And some patients don't even have the possibility to go for a flap. So then it's only have a silicone breast implant or have nothing. And for these patients who actually didn't have a choice because their body was not really good for a flap, I wanted to find a solution for them or another option where they were able to choose, just to give them a choice.
Can you please tell readers who are unfamiliar with the BreastQ, which is the patient-reported outcomes questionnaire that you used for this study, a little bit more about this validated questionnaire?
Yes. The BreastQ is actually the only PROM or patient-related outcome measure that really focuses on the outcomes of the breast surgery. So it's not so complicated, but the first time you see it's really a huge thing. And there are parts for reconstructive surgery in the breast, for aesthetic and so on. And you can divide it into several parts, and they are divided mostly into satisfaction with breast, satisfaction with outcome, psychosocial and physical functioning, sexual well-being. And all this adds up in the end to a score. And based on this score, you can evaluate how good patients feel or how patients see their treatment based on this score. So it's a really good and validated instrument to look at different types of surgery.
It also sounds like it provides a really comprehensive overview of breast cancer survivors who have reconstruction, who have breast surgery, and how they feel about their treatment.
Absolutely. It gives us constantly new insights. And each time that you use the BreastQ and do something new with it, you fall over new findings and you think, let us look into this or into that. So it really gives us new insights.
The pandemic had a clear impact upon your ability to complete this study because there were limitations on both enrollment and follow-up, which then resulted in not being able to include data from 12 patients who were in the autologous fat transfer arm. When I looked at the consort diagram, the largest attrition group was actually women who randomized to the implant-based reconstruction group and who decided they didn't want an implant after they randomized into that group. If you were to do a similar study again, is there anything different you would do to educate the study candidates prior to their enrollment to try and prevent that source of attrition?
That's a very, very good question. And actually, I have thought over the last years a couple of times about it. Would it have been better to do something different? But in the end, I really can't think of anything else. Why these patients really fell out is something that came into the media, especially in the Netherlands in the last years, which concerns the patient safety of silicone implants. A lot of patients felt that silicone implants may be unsafe. And so therefore we got these patients that either didn't want to participate in the study because they would have been randomized maybe to a silicone implant. So this is very specific for the Netherlands at the moment, and I don't think this is happening globally.
That makes a lot of sense, that it was simply something that was unavoidable.
Yes.
I want to take the opportunity to encourage the readers to look at the supplemental tables that are available that document the adverse effects and the serious adverse effects, because I know as a reader, I'm sometimes guilty of not looking at supplemental information that's out there. What was really striking to me when I reviewed it was the rate of both adverse effects and serious adverse effects for both types of reconstruction was substantial. It was not low. I am curious to hear more about how you discuss that level of complication rate with your patients when you're making decisions with them, because clearly this is surgery that is important surgery, but it is also not without risks.
Absolutely, no surgery is without risks. But we've been criticized by especially the government, which financed this study, that we are very, very critical about the adverse events because we take every adverse event with us into the study. But we didn't want anyone to comment on our results, that we may be not reporting everything, that we're maybe biased. Therefore, we were very critical to include all of the possible adverse events into our analysis and not to leave anything away. And the adverse events are pretty much what you would expect. So it's mostly some hematoma, some pain and itchiness, what you would expect if you're undergoing a liposuction or if you're undergoing an operation of reconstructive purposes. What is more striking are the serious adverse events. And when you look at this, it's not something we didn't expect because everybody knows the data that is out there about silicone prosthesis and the reconstruction process and what serious adverse events there are. There's a lot of infection going on when you place an implant, and the chances of it are pretty high. But to see it in your own data, it makes you aware of it, that it's really out there, and you have to discuss it with the patient. You have to discuss, there is a real chance that the implant will infect, that you have to take it out. And this is something that me personally, I took it over in my practice completely, and also my colleagues. So we are not the right place to go if you want a silicone implant anymore, because we've seen what we can do with autologous tissue.
So really, it sounds like that you have moved in a direction with all of this, that it's been practice changing for your group.
Absolutely. When I think about it, if I see a patient in front of me, I have to think about it. If this was your mother, if this was your wife, would you do this operation to your mother or your wife? And this is something which really, gets you thinking.
What fascinated me the most in your findings was that the autologous fat transfer patients were more satisfied with their results following reconstruction. And I think that the reason that stood out to me was because these reconstructions require more procedures across a longer period of time, which I would generally assume would result in people perhaps being less satisfied, but in fact, those patients were happier. Do you have thoughts on why that's the case?
Oh, absolutely. My patients tell me that all the time. If you go for the silicone implant, then you have it the more easy way. So the reconstruction is faster. The patient doesn't have to undergo so many operations or such big operations. But in the long term, patients have to live with the silicone implant, and they feel that there is something strange in their body that is not really feeling really comfy. So patients that are reconstructed with autologous tissue say, yeah, this is just a part of my body. This is something that feels naturally. Okay, it feels a bit more numb. It feels not completely as my breast before, but it's pretty close to it. And this is a big difference. And we see that also in body perception, because all the liposuction we do improves the body shape. So this is also something that you can put down on the positive side.
Was there anything that surprised you when you started to analyze the data from the study?
I actually thought that people that would go into the autologous group would be happier even faster after the operation. But if you look at the data 6 months after the operations, the differences in patient satisfaction are not that big when they finish their results. But the changes increase if it takes longer. So 12 months after the last operation, the differences were strong. So I thought people would be happier in an earlier phase, but this is something that surprised me a bit.
What are your next steps with your work on reconstruction following breast surgeries?
The next step at the moment is that we have just implemented this in the Netherlands. So the Netherlands is the first country that lets patients choose for this option as a standard reconstructive option, and the governmental insurance pays for it. So this is for us a big step. So we are going into implementation for the next years. We're going also into the oncological safety, and we hope that we can broaden the spectrum for indication also to radiotherapy patients. So these are the next couple of steps that we're taking.
Dr. Piatkowski, thank you so much for your time today.
Thank you very much. It was a pleasure.
This episode was produced by Shelley Steffens at the JAMA Network. The audio team here also includes Daniel Morrow, Lisa Harden, Audrey Foreman, Mary Lynn Ferkelek, Hannah Park, and Dr. Linda Brubaker. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.